All right. Good morning. Welcome to the Department of Medicine Grand Rounds. We have an interesting one today. Before I jump into inviting our moderator up here, the CME code for today is 31642. A couple of reminders. We have our Department of Medicine meeting today at lunch. Tomorrow morning for all trainees, there is an Art of Medicine series. And then for faculty who are expecting their trainees to be with them in clinic, there is an Art of Medicine series for all the trainees in the morning. And also we have coming up in a couple weeks our first faculty development session of the year with Catherine Chen. There's emails that are going out if you're interested in learning how to be a preceptor or an educator who helps with our trainees and learners in developing QI projects. That's what Catherine Chen is going to lead the session on. So there'll be emails going out. Please RSVP for that. So to introduce our moderator for today, Jay Naik is the Vice Chair of Clinical Innovation. Jay isn't just a clinical innovator. Jay is a true innovator. When Jay and I sat down and talked about how we could lead a Grand Round session where we could feature what AI can and can't do, or large language models can and can't do, we came up with this idea, which Jay is going to talk to us a little bit more about. Hopefully it's a fun and exciting one, and we welcome your feedback after it. Thanks, Jay.
Good morning. Good morning. Can everyone hear on Zoom? Yeah. Okay, great. Good morning. Yeah, this is going to be an interesting one. We were initially thinking about having a wrestling match up here with a robot maybe, but then we decided to go with this. So first, I just wanted to say I have no real conflicts to disclose. I know it's just an advisor to a company, but there's no financial nothing related to this at all. We wanted to talk a little bit about how large language models work today to help all of our learners and folks that are using large language models to really understand what the limitations are and where it kind of excels. And we thought that the best way to do that would be to kind of go through a clinical case together, see how the LLM is thinking through a case, if it hallucinates, where it hallucinates, and then also see how an expert diagnostician is thinking about a case and how those two may compare to each other. So first I wanted to talk a little bit about what a large language model is. I mean, most of us are using large language models like almost daily, maybe constantly these days. When I was a med student, we had this pocket medicine green book. And then when I was a resident, we only used UpToDate to like look up information. And now when I'm on the floors, all I see is folks on open evidence. Like when a medical student, any questions asked, they're always using open evidence. Residents, same thing. So when we talk about tools like Open Evidence or ChatGPT, they're built on these models called large language models. And at a very basic level, these models are neural networks designed to recognize patterns in language. Most modern LLMs use this machine learning technique called, or architecture called transformer, which allows the system to understand relationships between words across entire sentences and paragraphs. A key concept in how they learn is something called supervised, self-supervised learning. And unlike traditional machine learning models, which take data and then have data labels, these models learn from massive collections of textbooks, websites, and scientific literature that have no labels. The training task is actually quite simple. The model repeatedly tries to predict the next word in a sentence. So you can think of this training as a giant autocomplete game. And here's an example of an autocomplete game. And so if you wanted to play it and feel what a large language model does when it's training itself, you can scan that QR code and play that game. If a model, basically what the model is trying to do is if it sees a phrase like patients with uncontrolled diabetes are at increased risk of, it tries to predict what the next word in that sentence would be. Words like neuropathy, nephropathy, cardiovascular disease are likely to come next. And so during training, the model makes these predictions billions and trillions of times, and each incorrect guess slightly adjusts the model's internal parameters so that the next prediction is more accurate than the prior. And over time, by playing this game again and again and again, it gets really good at the game and it learns grammar and concepts between and relationships between ideas. So you can play that game and kind of get a feel for what that looks like. Another key concept is tokenization. So computers don't really read full sentences the way we do, and instead they break apart words into smaller pieces called tokens. And these can be full words or parts of words. It can be punctuation. Each one of these tokens is converted into numbers, and then those numbers are used in neural network processes mathematically. So when you ask a question to an LLM, the model converts your text into tokens and generates a response one token at a time, predicting what's statistically most likely to come next. One important thing that we want to understand, and something that you hear frequently, is about this concept of hallucinations. And so inherently, because the model's objective is to generate the most probable next sequence of words, it is not actually retrieving any facts like a Google search engine does from any database. The model doesn't have, if the model doesn't have strong information about a topic, it may still produce an answer because that's its goal, and that answer may sound fluent and confident, but it often can be incorrect or fabricated. And this is the phenomenon that we call hallucinations. And here's an example of one. So I asked Gemini last week what high school I went to. And it has no idea, but it knows that I'm an Indian male in New Brunswick, and it put me in J.P. Stevens. But I went to Rutherford High School in Bergen County. So in medicine, systems like open evidence try to reduce the risk of these hallucinations by connecting the model to retrieval systems and curated medical literature, allowing responses to be more grounded in peer-reviewed evidence and citations. So the risk of hallucinations is slightly less, and there's other techniques that are used to reduce this risk. But I just wanted to give that key takeaway that large language models are systems that are trained through these self-supervised learning models, and predicting the next token is their goal. And that training process can produce really, really powerful language capabilities, but at the same time can produce these hallucinations. All right, so now getting down to the showdown. So today I want you guys to put your hands together first for Alex Todfield, who was our intern, and did this. Alex, you want to stand up? So, Alex is an intern in internal medicine, and he's one of our star interns, I'd say. And he used a large language model with me over the weekend to go through this case. And so during this grand rounds, we're going to see what he inputted into that large language model, what the large language model, like what information it gave him, and then how he developed a differential throughout the case as we go through it. Then I'd like you guys to put your hands together for our true guinea pigs today, who are Dr. Jag Sunderram, who is the Chief of Pulmonary Medicine and also the Vice Chair for Research in the Department of Medicine, a full professor, and Dr. Gabriela Ferreira, who is the Director of the Sub-I program here and an Associate Professor in Medicine. Both of them are very well regarded as some of our expert clinicians here, and so we thought it'd be really fit for them to do this task. So what we're going to do next is I'm going to present small snippets of the case, and we're going to keep going through the case. Alex is going to give a differential, and so is Dr. Sunderram and Dr. Ferreira throughout the case presentation. They're going to discuss, and then I'm going to show you what the LLM told Alex. And then you're going to get to vote at different parts in the case as the audience on whose thought process you agree with more, whether it's the clinicians or Alex and the LLM. Does that sound okay? Yeah.
What system did you use?
Open evidence. That's what Alex decided to use. Yeah, we could use anything you want. Or we gave him the option to use anything he wanted, but he wanted to use open evidence. And then whoever gets the correct diagnosis, we're going to look to see who gets the correct diagnosis first, and what order they rank that correct diagnosis in. All right. So.
Just keep your mouth shut.
Ferreira, you're crazy doing this.
I agree.
So we can get started now. All right.
I feel that way, like, why are we doing this?
So to start, the case is a 76-year-old man who presents to the hospital with syncope. Yes, start.
All right, so 76 and has syncope. So when I look at somebody like this, the things that I think about is the age, sex first. That brings up, the differential diagnosis and something like this. And syncope obviously could be either neurological or cardiac in nature. There are other reasons for syncope, such as cough and micturition syncope. There's no details that I have here. So my top three that I would think of is either it's a cardiac issue, arrhythmia that led to syncope. The other possibility is that the patient has some kind of neurological issue, 76, potentially autonomic dysfunction that led to syncope, postural hypertension, and entropic. So cardiac and neurological are top two in my opinion.
Yeah, I think the other things I would add, so orthostasis autonomic, and then vasovagal is very common as well, and then just volume loss for whatever reason. So those would be my additions.
All right, so your top three are?
So arrhythmia,
Okay, one.
is that?
Yeah.
Well,
arrhythmia including heart attack.
yeah, any arrhythmia, cardiac cause. Volume related like orthostasis or postural hypertension, autonomic dysfunction. And you want to do vertebrobasilar or no?
Sure.
Alright.
Yeah.
Okay.
That would be
Louder.
All right, sounds good. So arrhythmia or cardiac you had first, and then second was postural, orthostatic,
autonomic,
postural,
yeah,
autonomic, and then third was
but vertebrobasilar.
vertebrobasilar. Okay. All right, and I'm going to give you the second part of the case now. So the patient was well in the morning and went to an outpatient primary care appointment with his wife, and after getting to the appointment, he felt progressive lethargy and became unresponsive. He woke up in the emergency room. He had a similar event about 2 weeks ago where he was worked up at an outside hospital, and the workup reportedly was negative, including a CT head and an MRI brain.
I mean, that's always the case. The CT heads always know. So he felt progressively lethargic in the office.
Yeah, you can actually look back if you want.
That's okay, no, I don't want to
Okay.
go back, otherwise I'll start. So, and I can ask any questions. Yeah. So I would say probably, arrhythmia per se would be less likely, but if it's ischemically driven, he could have been having an MI while he's sitting there and felt, yeah, but maybe he's having angina, I don't know. Anyway, so I don't think, arrhythmia seems less likely because it's not so acute, but nothing's ever simple. So I think definitely VBI is still up there. Don't you think vertebrovascular? Like some kind of neurologic.
Yeah, potentially. The thing
And then
that
postural.
bothers me is this fact that it was progressive method.
Right.
It's not an acute trauma.
Right.
So to me, that makes cardiac less likely, like an arrhythmic event
Mhm.
compared to the syncope. The fact that, he was okay, he felt suddenly lethargic, and progressively lethargic, leading to unresponsiveness, that means, like you said, there's either a vascular event that's causing this progressive lethargy, which indicates the neurological, the reticular activating system being affected, leading to the lethargy, right? And so I agree that vertebrovascular insufficiency, which a TIA like that disorder leads to that progressive lethargy, is more likely than a cardiac arrhythmic event that made him drop. The fact that he loses consciousness and then he wakes up in the ER, so potentially, he went to an outpatient appointment, so it's not like the syncope led to him losing consciousness and then him recovering consciousness right away. Right? That to me tells me that this is not something that you have a hypotensive event, like vasovagal, they drop, and then as soon as they drop, they get perfusion back to the brain and they wake up. So, makes it a little more complicated.
Yeah, I mean, my thought when I initially heard that, he was in the office and got progressively was, he took his morning meds, didn't eat, went to the office, got more and more hypotensive because his meds kind of kicked in. But again, he shouldn't have been out that long, if that was the case, yeah,
That's right.
so,
But it could be that the meds interacted with a baseline, particular baseline insufficiency that led to the hypertension and prolonged that. And
we're not told that
happening now, a negative CT head and MRI
means nothing, yeah.
is not a problem because it's not the right workup.
But also I think, so what, if he had VBI, why would he be out so long?
Yeah.
We don't know that he had seizure episode or not, we're not told, but,
Right.
Hey, Jacob, I just saw this email. You've decided to keep that NSR?
Someone needs to mute, yep.
yeah. So what's our
top three,
top
yeah.
thought right now?
So we're moving towards more of a neurological event, a particular baseline insufficiency,
With,
vascular.
yeah. Without additional information.
Yeah, whether that was led to a seizure and he was supposed to
Right.
why,
That's what I was wondering.
potentially that's right.
Or if he fell and hit his head and then had post-concussive amnesia.
The problem is he had a similar episode 2 weeks prior to this and had it work. And-
Well, who knows? They probably did a CT head and MRI as well.
No, I mean, like this is rigor.
Uh,
So the fact
Can-
that he hit his head, I don't think.
Can we get three diagnoses?
Yeah.
Sorry, yeah, just for time. Yeah.
Spoken like true insurance.
Okay, so you have to write this down.
Yeah, I'm right.
Okay.
I got it.
VBI, or some kind of neurovascular, maybe complicated by a seizure.
Yeah,
I still think 76, I don't know, progressive hypotension, I still think is so likely in this age group because they're so polypharmacy and they take so many meds, even though it shouldn't be out that long, but I still think should be,
Alright, and for the audience, we're gonna have you vote on whose thought process you agree with more so far and whose differential you agree with more. So if you can text 37607.
I just wanted to add one. Can I?
yeah, we're not done.
Yeah, so, we're not done with the 3, but, if this was a much younger individual, the thought that comes to mind is a cataplectic episode.
And it's DAC UNC. So text DAC UNC to 37607 to join. And then you can vote for A or B. A is Alex in the LM and B is Dr. Ferreira and Dr. Sunderram.
Alright, so that's one of the 3.
So what's the third?
I don't know, what's the second one?
Neurological.
What's the first name?
CPI,
VBI, neurological, what does that
or
mean?
seizure.
Oh,
And the vascular, you said it was hypotension.
I think, oh, stop it, you get up here, okay?
What are you going with? So I heard vertebral
I
vascular.
still think hypotension is, I don't know how to
So,
explain it.
drug review?
I think drugs induce hypertension, I don't know.
Okay.
We'll put that in there. We have to give it a.
All right. Are we gonna go to the next part? But it looks like we got a 70-30 split here.
76-year-olds always have too many drugs.
Got it. All right. So the next part of the case is just the past medical history. So the patient has diabetes and is on metformin and has hypertension and is on chlorthalidone and fosinapril. He does not have any surgical history.
So, hypoglycemia shouldn't occur with metformin, so, is he on metformin? Yeah, so that shouldn't be, that should be an issue metabolically.
he is on chlorothalidone
And-
Fosnap Road.
right, so
The theory that, chlorothalidone maybe dehydrated and he got more lethargic.
well, maybe he's hyponatremic, and, because it wouldn't be, hyponatremia would make a little bit more sense, I would think. But hypertension, I think, would still be, up there. But still, it could be leading to a neurovascular problem, right?
Yeah.
So I think we still have to, so I think I would still keep,
So are we moving drug-induced hypertension higher up in the differential because of the meds he's on diuretic, he's on ACE? And I'm wondering if, and metabolic dysfunction like hypernatremia led to a seizure that led to the prolonged unresponsiveness, because I'm still.
it's weird though, because I mean, you have to be really low for it to happen. I've never had one
Well,
seen one seizure.
Less than 190 when you start to
Right.
see seizures.
Right.
We don't know, and again, what bothers me is that he had a whole workup 2 weeks prior and they didn't find it.
And I don't think it was happening to me, you know why? Because he felt fine in the morning. Like, would he really feel fine? It was happening, I don't think.
I'm gonna have to push it for top 3 again.
Okay,
Do you want to move up the drug abuse?
I would,
Yeah.
yeah. Like I say, drug induced what? Hypertension leading to,
The sympathy, yeah. So that's one. I still think GGI is in there, so that's number 2. Really want a third one?
drug induced VBI, drug induced meaning what? Not hypertension and,
Hypertension, and that led to the sympathy. We don't have a great
You can still-
explanation as to why.
but he could still have like, he could have like critical AS and have hypertension,
Right.
So that would be another thing, so it could be valvular, but still cardiac, but.
Alright.
That could be multifactorial.
All of the above.
So something like, no, well, I think I agree with you, Gabby. I think the point is that, well, he was on these medications, he has something that affects his cardiac output, takes the medication, gets lethargic because the cardiac output drops, and then he's, so I think, can we say multifactorial?
Yeah.
Yeah, but which factor? Just write 1 or 2.
Drugs and cardiac.
Okay, sounds good. All right, I'm gonna move on to the next part. And so the vital signs are, he was afebrile, temp was 98, the heart rate was 100, the blood pressure was 80/50, the respiratory rate was 18, and he was satting 99% on room air.
Yeah. Yeah,
Well,
either critical AS or critical like coronary disease, like,
the one thing that does bother me in these vital signs is that the heart rate is 100 or a blood pressure 80/50. Not a problem.
that
Should be higher.
it should be done.
Yeah, and raise up the pressure. You need to maintain cardiac output.
But when
How
you're
do you do that?
76, if you have
So,
conduction
autonomic
disease
dysfunction.
or conduction disease,
He has diabetes, so it could be autonomic neuropathy from diabetes. It doesn't allow it to have a appropriate autonomic response to hypertension. The hypertension was triggered by the drug.
right, and he's not on the beta cells.
Right.
What about AFib? That would, why would he suddenly
They
feel?
don't tell us about whether the rhythm is normal or
Right.
not. They just say it's 100 beats per minute. Yeah, so
So cerebral hypoperfusion still seems the most likely, and what caused it, whether it's from outflow or,
well, we know the blood pressure is still low
right,
in the ER, which means that, something to do with, impaired cardiac output and a poor response to that cardiac output, drop in cardiac output, right? So I would say that I think I'm moving more towards a primary cardiac problem, like AS or something that affects the cardiac output, but then he is on medications that led to that intensive episode. He has diabetes and potentially autonomic dysfunction that leads to the poor response, and therefore he stays lethargic
Despite that,
despite.
and despite being down.
Alright, what do we got? Number one is?
Well, I think it's primarily a cardiac issue. The second is that he had his drug-induced hypertension. Again, it's multifactorial, so I don't think I can say 1, 2, and 3, but this is what I think.
Okay.
Autonomic dysfunction from diabetes.
Okay.
So critical AS or some other outflow problem.
I'm gonna give you the next part now.
Yeah.
So the exam, in generally, he's lethargic, but he's AAO times 3, and he's following all commands. His HEENT exam is normal. His cardiovascular exam, he has a regular rate and rhythm, no murmurs. His lungs are clear bilaterally. His abdomen is soft, non-tender, non-distended. His musculoskeletal exam, he has no edema bilaterally. And neurologically, he has no focal deficits, though he is lethargic.
That was a cut and paste exam, right?
That was the exam.
The only thing here is there's no murmur.
So, half the time people
I mean, people don't know how to examine patients, so that's not surprising. Loudness, murmur.
No. First of all, I've missed murmurs in the ER, like severe amount of murmurs I've missed, anyway. I'm not,
I
it's not
don't
the
think we need to
essence.
change anything right now based on this.
So the AI can't do the exam, and you guys don't care about the exam.
Well, we care about the exam, we care about who.
I'm kidding, I'm
did the
kidding,
exam.
yeah.
We didn't do the exam, so
Yeah.
I don't believe a negative exam. And they didn't put orthostatus in there.
They did not, but his blood pressure is still 80. Yeah, I hope they didn't do it.
Does this change your differential?
No,
Okay, so you're gonna keep the same?
Yep.
Alright. Gonna give you the next part, which is the labs. So the hemoglobin was 13, the white count was 8, and the platelets were 204. His sodium was 135, chloride 105, potassium 4.3, bicarb 25, BUN 18, and creatinine 1.1.
Can't ask about the gap, right?
Well, we have some-
Well, you do it in your head, I can't.
I just did it.
doesn't change anything.
No, we don't have any additional information.
He doesn't seem to be bleeding. Or very hard thinking.
You didn't give us an EKG, did you?
Not yet.
Okay.
So keeping the diagnoses all the same? Alright. I'm gonna go to the next part then. So the imaging, so the chest x-ray shows a prominent aortic contour, and so they do a CT chest and abdomen in the emergency room that rules out dissection and PE, and he has an 8 centimeter renal mass. That's new.
What is a prominent aortic contour, mean like a prominent knob?
So
Okay, no.
potentially it could be either dissection, right, or
Or maybe just very
And-
heavily calcified aorta, right? And prominent.
calcified aorta would present a self-sufficient.
I know, but, yeah.
So I would think that the prominent contour indicates, anal. And that, but he has an 8 centimeter renal mass.
Yeah, but don't get distracted.
That's a red herring. Okay.
I mean, yeah, PE, but why would you get progressive PE? That makes no sense. You don't have PEs twice and then have progressive syndrome. That makes no sense to me. Right?
I'm thinking.
And renal doesn't usually go to brain, so that doesn't.
Yeah, I wish we had a little more history about what exactly triggered that, the whole thing. I mean, where is the mass? Is it, Is it on the superior pole of the kidney, where exactly? Is
Like
it
adrenal
obstructing-
mass.
Yeah, is it obstructing, circulation, turn some way, I don't know.
Yeah,
But there's no, like, edema there, is it?
and if you know he's not tacky, it's not diaphoretic.
Yeah.
Change your differential at all?
No,
Well, if you wanna add aneurysm or no?
well, and,
Aneurysm usually doesn't make you sick.
yeah.
I think it's some cardiac outflow problem.
Well, the possibility is that there is an aneurysm of the ascending aorta that leads to the aortic, valvular issue.
Right.
More
Like,
regurg than stenosis.
Mhm.
But that wouldn't, and 80/50 pressures, a wide pulse pressure is consistent with that.
but 80/50 isn't that high a pulse pressure.
Not terrible, but it's.
For a 76-year-old, usually it's, yeah. You would think for AI, you mean?
Yeah. But it will be a yes. That's. No, I don't, well, are we ruling out yes?
No, I wouldn't.
Okay.
But you can outvote me, but I think AS is still out there.
Yeah, Dr. Sengupta has a comment potentially.
One of the differentials I think you could entertain is if renal cell cancer goes to the IVC and somehow you have a reduction of the cardiac
Yeah.
output. So a combination of the medications and somehow it's manifesting in the low cardiac output.
That's what I was thinking, where is that mass, and is there extension, and we do know that venous tumor emboli to the IVC.
Not only, but you can actually get, I'm married to a urologist, remember, so you get renal cell in phase, the tumor goes up the IVC into the right atrium,
Right.
actually, itself. So if you had decreased right heart filling from that, that would definitely be a problem. And if you then had medications that made you hypertensive, but you felt fine, and then you took your meds, and then your pressure dropped, and you needed that right heart filling to feel good.
I mean, so
And any change to the,
diseases have to come sometime and they just manifested on that day. Yeah. With all this.
You're not supposed to help us, by the way.
that's okay, any change to your plan? We got a cards consult in the middle, so.
I think that decreased cardiac output mechanism, whatever that is, right?
So you're keeping number 1 cardiac syncope, like some sort of cardiac
I think
etiology
so,
syncope.
yeah.
And then 2 and 3,
Well, we said that the drugs precipitate.
drugs, okay, and then 3,
Yeah, well, autonomic dysfunction still.
alright. So still autonomic, right?
Yeah.
We're gonna go to the next part. So the patient was admitted, all his medications were held, and the blood pressure the next morning was 143/79. The heart rate was 80, and the patient was feeling well.
Yeah, so the drug effect went away. That's all I can say.
Alright, and I'm gonna let the audience vote again. Any change to your thought process?
No,
Gonna keep
I was
this-
just, the,
Medication do something.
yeah.
Sorry,
We
it's addressing the
keep
medication.
going back to the medications, and we say it's a prolonged hypotensive episode from the persistent effects of the medication on top of something that causes the low cardiac output.
On the voting, the tables have turned. So now it's a 75-25 split supporting our clinicians.
The thought goes out.
Yeah.
All right, and this is what the AI outputted, just so you guys have what the AI thought. No, can't tell. Alright, we're gonna move on to the next part, so you're keeping the same three, right? Or basically, you said medications, number one,
Causing some kind of
Cardiac.
some kind of inherent cardiac obstruction, whether it's filling or.
number two, and then three is still autonomic, or something else?
I think something neurologic still, I don't know. Caused by the hypertension.
Yeah.
I don't know.
Like seizure or something?
No, like perfusion.
Perfusion, okay, so like vertebral, VVI still, okay. Alright, we're gonna give the next
I
part.
still think that there's an impaired response to hypertension.
That's why you think the
Led
autonomic.
to the prolonged
Yep.
right? Because we shouldn't have been, I mean, okay, given maybe just the prolonged effects of the drugs that led to him being that long, but he's been on these medications. It was okay 2 weeks ago, he takes it every day, so it's kind of weird that.
But we don't know anything. The fact that we don't know, is this a new medication, did someone add it, we don't know any of that, like that's all very possible. So, I would,
Okay.
Alright, I'm gonna give the next part of the information. So, while examining the patient the next morning, his wife wasn't feeling well. She was euglycemic, and the blood pressure was 160/90. She reported she already took her blood pressure medications and attributed her elevated blood pressure to being in the emergency room all night. Over the next hour, she became difficult to arouse and had slurred speech.
Okay, I'm going to go out on a limb. My wife.
they're doing mushrooms, I don't know. Just having it, I don't know.
She spent the whole night in the ER, not at home.
The whole night in the ER.
Yeah, whatever.
Because if it was at home, I would take something like exposure to CO or something. Right? But she spent the night in the ER.
She's dehydrated and then she got stressed and anxious and got hypotensive and, no, she got hypotensive.
Because
Is this supposed to, is like our diagnosis of him?
I still think that an environment
This just happened, so whatever you want. So this is just a real world situation.
I just can't believe it's related. I mean,
well, if it is related, I think it's an environmental exposure. And
Let's
the
see, yeah.
most thing that I can think of is the toxins. And they get out of that environment, they're flying.
except this happened in a doctor's office, not at home.
Right.
Yeah, so.
Yeah.
And this is what the AI came up with for the audience.
I didn't know what to do with that information. I would just park it. I don't know if it would change. I mean, what environmental things would cause both of those scenarios?
Unless they will eat something that takes a while. But
They're
then,
being poisoned?
there's an elevated drug.
I think this, I don't know. More information.
We're gonna keep it all the same then, same three? Alright, so you still have medication-induced number one, cardiac number two, and then autonomic, like vertebral, some vascular related thing number three, right?
What?
Alright, and I'm gonna give you the next part. A code stroke was called for the patient's wife. Neurology identified right eye exotropia and impaired upward and downward gaze
On the wife,
on the wife.
because she had a cataract repair.
Neurology was
Exotropia, wait, exotropia is exophthalmos?
no exotropia.
Exotropia, oh, deviation?
Yeah.
Deviation of
Oh,
the right
I thought it
equal
was-
to the right, and an impaired upward and downward gaze.
Why does this matter to our patient?
That's a 6-note value of the right side. I don't know why.
I would like the audience to just pay attention to what differential number 2 from the AI. Because it's a hallucination.
This is nothing to do with the patient.
I agree.
So let's ignore it, let's ignore it.
Alright, and I'm gonna ask everybody to vote again. How do we clear this, David?
I would ignore it.
Oh, I got it.
You would ignore the whole thing about the
Right,
right.
yes.
having-
Yeah, I think it's distracting.
So, because But just coincidentally, that both our husband and
There's
wife have
Sandy.
slurred speech.
There's, no, he never had slurred speech. I thought he was just retarded, right? After G became unresponsive, doesn't say anything about slurred speech.
But she has this look
Well, she's not the patient.
she's not a patient.
She's not the patient, not our patient. She's another patient, we're not supposed to diagnose her.
Is there any change in your differential or keeping it the same?
I don't know, I wouldn't, but
Do you guys agree or do you just do different?
I'm going to Gabby for now, but.
Okay. All right, and now the audience is like 85% with you guys and 15% with the AI. All right, the next part. So neurology suspected a right midbrain stroke. CT head was negative and she was given TPA.
who cares? I mean, I'm glad that she was in the ER when this happened, and that she's gonna probably have good recovery, that's great. Right? I mean, this is like total distraction.
I just,
This is irrelevant.
it's too coincidental.
No.
Do you want to keep everything the same right now? Jag Sunderram?
I do, but
Gabby is the louder one.
I don't know. I just think, why?
Do you want to add anything?
I can't come up with an alternate
Yeah.
hypothesis, so
Yeah, so,
I'm gonna go with you.
okay.
I can't come up with.
All right, and okay, I'm gonna give you the last piece of information is coming out now, and that's that the brain MRI and MRA were unremarkable for the wife.
Or?
The wife.
How long after the CPA we're not allowed to ask? So you can have a normal MRI, MRA after CPA.
Well, they
If
don't
you-
tell us if the,
That doesn't, but I mean, that's not good for the patient.
no, but the MRI usually has,
Usually has some changes, even though if you get,
yeah.
yeah, that's true.
So at this point, I'm gonna ask you whatever three you think is most likely now, and then I'm gonna give you the opportunity to ask three questions. Any three questions you want. It could be history, exam, or like lab or testing, anything you want related to the patient or the wife.
Okay, so.
But first I need three from you guys, top three, and then I'll let you ask the questions.
I'm gonna, I don't think it's a neurotoxin, I think you're getting totally distracted. Game, right? I mean, I don't think so. And how common is that in some people?
Okay, so she presents with a stroke-like syndrome without MRI changes, MRA changes, which indicates it's a toxic ingestion. And he has the same thing.
No, he doesn't, he was hypertensive. He was not hypertensive.
Maybe that same thing caused hypertension.
But he can have focal neurodeficits. Yeah.
Okay, so
So-
this is a distraction.
I think so, but I don't know. I think so.
I'm trying to see what the story, two people with the same household.
No, I mean, I think the common things being common, I think I would look at other common things for his syncope first. And then if that proves to be negative, then you might try and look for something more complicated that might affect both of them. But that wouldn't be my first diagnosis.
Okay.
So I think I would still, common things being common, I would say some kind of cardiac, some hypo perfusion related to low output, whether it's from right heart filling, outflow obstruction, medication triggered.
Right, so in him, it was medication induced hypotension, but then
On
in
top
the
of it.
presence of some form of right,
Some kind of,
outflow obstruction,
Or-
potentially from the renal cell
right,
that led to his sympathy.
Right.
The wife has a TIA in the meantime. A great set TIA,
right.
and she's fine.
He's not on the statin, which for 76-year-old with diabetes and hypertension is kind of,
Alright, so you're keeping the same differential, is that right?
For the guy, Yes.
Yeah. All right, so we'll keep the same three, and then this was the final three that Alex gave me. And we're gonna have you guys vote again before we ask the next part.
Awesome.
Because that's where I went to residency.
Right. Are we supposed to do something?
Not yet, not yet. All right, just think of the questions you want to ask.
Echo?
Three, you get three. Any three.
Echo?
Yeah.
Do I think? And then we
Yeah, I
get
think it.
right heart,
Yeah,
outflow, overlap.
Yeah.
Right.
but I still think I wanna ask, given the data they're presenting on the slide.
These were the three questions that Alex asked. And the results of those questions.
I'm gonna bet, I mean, I want an echo.
Okay,
Yeah, that's fine.
okay,
Yeah,
so
there's two other
so
things.
we'll give you one echo.
Yeah, there's two other things you can ask for. Do you think troponin? Doesn't sound right.
No, I don't, I'm more interested in,
The
I
MRI.
know you discounted the whole,
That's fine. Well, no, that's what I'm saying, so you should, if
So
you
I'm
think.
wondering about the environmental exposure.
So how, what are you gonna test?
Question about where they live, what kind of apartment, what's using.
What kind of question, sorry?
Kind of environmental,
Environmental, like history?
Yeah,
Okay.
like their living situation, was it the winter, was it summer,
Sure,
kind of
I'll,
housing they had,
okay,
what did they eat, did they eat this mushroom?
That's number two.
okay. And then number three?
Number,
The wife had an MRI.
he didn't have any, he had a CT only, right? Oh, he had an MRI brain, okay. He had an MRI brain.
2 weeks ago, yeah.
Oh, 2 weeks ago, yeah, but that, yeah, the same episode. So you don't see VBI on MRI, right?
No,
You see it on
but if
MRI.
you're just saying insufficiency, you know. Yeah, MRI, well,
Or CTA.
Is that an MRI, right?
No, it's an MRI, she had an MRI, that's the whole distraction.
Alright. Or, so, if you go back to the theory that the renal cell carcinoma, the echo would show us enough evidence, we don't need any more imaging.
Or something like, he had a CT chest,
Yes, he had a CTA chest and abdomen.
And
Oh,
I
it did?
was
Yeah, it just showed a dissection.
Yeah, but.
I mean, no dissection. There was no dissection, no PE, and that's where you found the renal cell.
Yeah, but you won't see an endovascular renal cell going, I mean, you won't see it
on
on
the CTA,
Oh, on CTA you might, right, because you can see film defect.
yeah.
I would still get an echo. I would probably get an echo and an MRA, that's probably what I would do, but I don't know for a fact.
So which one do you want to do? So those two.
Yeah,
What are the,
Echo,
MRA,
MRA of the
Yeah.
brain?
right?
and environmental history, you said, right?
Yeah.
Okay,
You
So-
sure?
I'm gonna give you the results.
Okay,
All right, the echo was normal.
Uh-huh.
The MRA was normal.
Uh-huh.
And the environmental history did not show any signs of carbon monoxide exposure. It was winter time in New York City, and there was no known food ingestion, no history that we could elicit related to that. All right, now you get to pick the final three diagnoses in the order that you think it is.
I think
These were the three that Alex and the LLM came up with, so this was their final three.
a normal echo would rule out significant valvular disease, but you should see at least AI or, that is. So I'm thinking more the thing that you would miss would be if you had right heart filling problems.
Didn't see it.
No, from the,
I think the echo, if there is something in the RV or the right aging, you're gonna see it.
but maybe not when his pressure's normal.
See,
Let's see, yeah.
I don't think, I'm assuming a normal echo done well is going to rule that out. And a CTA of the abdomen and chest didn't show any filling defects, nothing.
No
I'm gonna-
aneurysms. No aneurysms,
No.
no CTHF.
Yeah, no. So I'm actually moving towards, it's drug induced, prolonged hypotension. And I still am going back to the fact that this guy has diabetes and probably a poor autonomic response to the low blood pressure. And that's what led to the sympathy. And I can't explain what happened, why he had a
Stress.
Yeah, that's,
So we're saying, you guys are saying number one is medication induced. Number two is,
I think there is some autonomic dysfunction.
okay, so maybe autonomic dysfunction, and then number three,
I don't know if we have a number.
Yeah. We just ruled out all the environmental stuff. I don't have it in the sheet.
Unless it's seizure, and then culminating in a seizure, no.
it's good, all right.
Prolonged postictal is the only thing, I mean,
Yeah, but there's pressure.
So you'll take prolonged postictal, or, yep, anything you want, number three.
sure.
Yeah, okay, all right.
Okay, yeah, sure.
So now, this is like the most interesting polling we saw. Like it first started at the LLM winning, and then 50-50, and then as you guys were talking, shifted to 70-30 for you guys. It's very interesting. All right, so I'm going to tell you what happened. So because both events happened where the wife had the same sort of symptoms, we were really concerned that something was like some environmental cause was uniting the two. So we checked their pill bottle, because it turned out that the wife had actually taken the husband's medicine that day, because she was in the ER all night with him. So she took chlorthalidone from his bottle. It was a chlorthalidone bottle, looked just like regular chlorthalidone dispensed from the pharmacy, but we still had a high index of suspicion, so then we had the pharmacy identify the pill that was inside the bottle. It turned out to be Clozaril, which is an antipsychotic. And it was a misdispense by the pharmacy. And so we got in touch with the pharmacy and found out that it was indeed misdispensed. And it was like, it just happened to happen. And so what the way the history went was 2 weeks ago, the patient had presented to an outside hospital because that fill of chlorthalidone was actually Clozaril. And they went to the hospital, got admitted, got this $1 million workup that was negative, and then was discharged on hydrochlorothiazide instead of chlorthalidone, because that was what they had on dispensary in the hospital, and so they discharged on the same meds when they left. And so the patient was good for 2 weeks. Went to
Wait, so the Clozaril was in place of the chlorthalidone, but he wasn't on the chlorthalidone, he was on hydrochlorothiazide.
he was getting Clozaril 2 weeks ago,
Right.
until he presented to the hospital.
Right, then he stopped.
Then he stopped, and then got hydrochlorothiazide on discharge.
Right.
So for 2 weeks he was well.
Right.
He went to see his outpatient primary care doctor, who's like, why the hell are you on hydrochlorothiazide? Chlorthalidone has a better half-life, and it's more effective. Switched him back to chlorthalidone.
And he took his old pills.
He took his old pills, came back to the hospital with that.
Give us any of this story.
Well, we didn't know any of this story. We knew
It's
this.
crazy that you
Yeah,
were able to figure that out.
yeah. It
So
was.
you were right, Sundar, it was related.
It was
The wife and the
medication
son.
induced. Yeah.
Well, no, but the wife and the husband were,
It was
It was
related, and
linked.
it was an environmental factor.
Yeah.
There was a Let's go come up with which toxin.
no, you're right.
But the questions you asked, the winter season, the carbon monoxide, all of that wasn't there. But you were definitely way closer than what the AI came up with, which was still the thiazide. I wanted to show some interesting.
What did they act on?
The AI said thiazide / orthostatic hypotension, vasovagal syncope, and seizure as the top three.
It's not bad though.
But some things were interesting. At some point the AI said diagnosis confirmed, chlorthalidone-induced hypotension, and it like clinched on something, and it made a very convincing argument. So somebody reading this might have thought that was the case. And then there were a couple interesting things. So like at one point it did mention medication toxicity and accidental ingestion. It mentioned that the wife mentioned she already took her BP meds. Possible scenarios to include are accidental double dosing, accidental ingestion of husband's medications, and then sedative hypnotic medication effect. But it all depends on the clinician using the AI as the index of suspicion to decide whether or not to make that primary. And then the most interesting one was this one where it said shared cardioembolic source causing posterior circulation strokes in both patients. And so that was a hallucination that it came, a differential that it came up with. Yeah, even though it says it's less likely, but listed at at number 2 at the time for most.
And this, the events that you described actually happened in real time.
This
actually happened.
This actually happened in real time. Well, we went the next morning, and that's exactly what happened. Yeah, and so for now, I guess we live to fight another day as a clinician. And I'm gonna have Alex come up and just kind of talk a little bit about his experience with the LLM and what his thought process was. Come on, Alex.
All right, so I essentially played this like exactly how I had to play it, like a busy intern that was on floors, that had a whole bunch of patients, that was getting patient calls in the middle of doing this exercise, and I played it essentially exactly like somebody who's just using AI to formulate a differential. So in terms of what I was actually doing, I was essentially combining things that the AI had suggested into kind of like big categories. So like when I was saying orthostatic, I was saying like essentially things like the thiazide, things like medication-induced, multifactorial. That was essentially my big bucket for multifactorial LOL. Then cardiac, they had never given me an EKG or tele or a TTE the whole time, so that's essentially what I was thinking. And then the adrenal insufficiency was my paraneoplastic. Did it spread to the adrenals? Was there like a metabolic encephalopathy? And then in terms of my top 3 questions, those were all things that the AI was bugging me to do. It was pounding its fist on the table to get a carboxyhemoglobin level instead of just asking about their environment in general. And then obviously tele and an EKG, and last but not least, an ionized calcium, because the AI was essentially thinking like renal cell carcinoma and like metabolic encephalopathy. So overall, I think the way we use AI, I think that we need to be careful. Because one, the hallucination, me and Dr. Naik caught that right away. The both of us essentially saying that they had a shared cardioembolic event. And I see this all the time. We use AI on the floors, especially as interns and as residents. One, to get evidence to back up our differentials and also to expand our differential diagnosis. So I think that we really need to be careful what we're looking at and make sure that we're not missing anything. And also the thing that I think is really important that I didn't have time to do during this exercise was open evidence always cites the studies that it's referring to. So I think that it's important to make sure that we're actually looking at the data itself that open evidence is using rather than just the sentences that open evidence is giving us. But yeah, that was my experience. It was awesome. It was really fun.
And if we get a round of applause for Dr. Sunderram and Dr. Ferreira. I think they did a great job, and their thought process was completely in line with finding the right diagnosis if you had like that patient in front of you. So, yeah, no, definitely. I mean, you guys came up with medication induced as number 1. So, great job. Thank you guys for entertaining us today. See you guys.
That's crazy case.
Yeah, well, it's the thing that they switched